At this time, I am delighted to introduce Jim Comerford, who was the third member of our team of 3 and worked with me for a year putting Cancer Day together. And when I say year of 3, the entire patient advisory team worked for a year on this event, but Jim Comerford and Jane Foster and I have met monthly and weekly and hourly as this event has come close. So it's really been the 3 of us, the 3 musketeers you could call us. So let's welcome Jim Comerford.
Fortunately, it's not like that old movie, The Three Musketeers, Men in Tights. It has been quite a fantastic experience working with Deborah and Jane and the PA team members to put this day together. And my essential role in the whole thing, that I hope at least some of you will appreciate, was to make sure that Jane and Deborah didn't schedule this event for Super Bowl Sunday. So, just a quick comment. I sat in on the session paying for your cancer care, some of the financial implications and some of the traps that you can run into there. It's a very complicated area, but it reminded me to, to mention that there are a lot of questions, not just about the financial side of care, but many of the things we've heard about today, treatment, clinical trials. We'll hear a little bit about. Anything any questions that ever come to mind about cancer care. The survivorship program and Deborah's office is the go-to place. The resources there are phenomenal. She is well networked and linked with resources, as you can see, throughout the community, with staff at St. Mary's, with other facilities, financial resources. So the phone number is on the poster that you have, or that's her direct phone number, website, whatever. But any questions you have going forward, or if you know of others who need information, that's your go-to place, is the survivorship program. With that, it's my pleasure and honor to introduce Dean Putt, who probably has the best looking shirt in the entire place today. Dean is the director of the St. Mary's Regional Cancer Center and is relatively new to town. When I saw him earlier today, I said, "So you've been here a couple of months now, haven't you, Dean?" And no, he's been here since July. So he's been around a while and comes to us from Yuma, Arizona, and has experience there, and prior to that, in managing regional cancer programs. And we're delighted to have Dean, and he will introduce our panel and get everybody ready. I hope you have lots of questions, because we have lots of expertise here to provide your answers.
Thank you, Jim. Appreciate that. Really the purpose of a moderator is to be kind of in the background, kind of unseen. So I'm not sure why I wore this shirt today, but at any rate, I'm really happy and honored to be here. We have a great group, and hopefully we can get all of this done in an hour. I'm sure there's a lot of really good questions. I know there are. I have them right here. We'll go down the line and introduce each person real quickly. So we have Dr. Leach, who you met earlier this morning, physical therapy. Stacy, Sherry, sorry. See, I saw too many people out there. So Sherry gave a really good presentation on nutrition, a lot of good questions for her. So we're happy to have her. We have Dr. Tian Pandit, medical oncologist at St. Mary's. We have our CEO from St. Mary's, Dr. Brian Davidson. Thanks for staying all day. We have our Dr. Doug Rock, radiation oncologist from St. Mary's. So happy to have him. Dr. Michael Trowbridge, surgeon from St. Mary's. Thanks for joining us. And Dr. Marty Jacobson, Director of Research at St. Mary's. So the first question I have is for Dr. Davidson, and it's, what is St. Mary's doing to prepare for our aging population?
Well, thank you very much. That's a good question. So if you look at the service offerings that St. Mary's has, our main focus is on those that are growing. And due to the aging population, cardiovascular services, neurology and stroke care, and certainly oncology top the list in just growth. So we're looking for additional physicians, additional advanced practice providers, new programs, new services. And sometimes, if you saw the City Council a week and a half ago or so, we just got approval for a very large, about a $50 million cardiovascular services center master plan approved. So these are some of the things that we're doing. Of course, when it comes to oncology, that area is growing exponentially as people get older and older. So that's one of our other focus areas as well.
Thank you very much. And Dr. Rock, I think this question would be a good one for you. It is, how is lung cancer diagnosed and treated in Grand Junction? Pretty wide open.
So Marty, maybe to answer part of that, there's actually a new, there's new ways of screening for lung cancer now, and we have a low-dose CT screening program for patients that are higher risk for lung cancer. So a lot of our cancers now are actually diagnosed through screening, and that's the best way of diagnosing it, because usually that's where you catch it when it's an early stage and a very curable cancer. If patients, prior to that time, and still we still get patients who come and they're a little bit more advanced because they already have symptoms of it. So we're trying to catch it early with this low-dose CT scan, where patients come in and get a limited low dose of X-ray CT scan to look for lung nodules, and then we take that to we have a multidisciplinary lung conference that we hold once a week, where we have pulmonologists and radiation oncologists and medical oncologists and radiologists and pathologists. We all get together and we review cases, new cases, and discuss how best to treat these patients so that we can all be together and be all on the same page as we go forward and treat them.
Thank you, Dr. Rock. Next question is for Dr. Trowbridge. Are you able to use robotic surgery for cancers of the head and neck?
You know, the robot has been useful in certain areas in medicine, mostly areas that are very difficult to access without making large open incisions. And so the robot originally started mostly in general surgery or abdominal surgery or thoracic surgery because the access to those areas required a big operation. In the head and neck, it hasn't been as difficult in terms of surgery access. We have lots of tools and lasers and scopes and other things that we've been able to access the mouth or the throat or even inside the neck. There are some people using the robot in different locations in the country for head and neck surgery. We currently don't use it here. I think in our practice we've sort of made the conscious decision that the benefit of the robot versus the extreme cost of the robot for most of the procedures we do, it's difficult to justify its use. It's awful fun to play with, but we have lots of technologies kind of up to the robot that allow us to take care of head and neck cancers in a really sort of more minimally invasive way, which is kind of what the robot is looking for. I expect that will expand though as time goes by, and I think the kind of the new set of ear, nose, and throat surgeons are all going to be robot trained, and everybody's always looking for some way to use the newest and fanciest technology.
Thank you very much. Next question regards research. It is a pretty open question, but important. What is a clinical trial, and why should I sign up for one? Dr. Jacobson gets to answer that one.
So a clinical trial is basically a way we bring new drugs into the clinical setting. They have to be tested in humans before we can, the FDA will approve that drug. So a clinical trial is an opportunity for patients to contribute and to help bring new medicines forward. That's one reason why, as a cancer patient, for example, you might be willing to participate in a clinical trial. And I say willing is because it is a choice you have to make. As part of a clinical trial and that choice, you also have the opportunity to say no, or you can say at some point in time, I don't want to do this anymore. A lot of people think that a clinical trial, you're going to be a guinea pig. That's a misnomer. At the very least, in any clinical trial, you're going to get what is called standard of care, plus the opportunity to receive maybe an additional novel drug, a novel agent. Why should people participate? Well, we can't advance new drugs without having research occur. And so we ask that people consider and think about their participating in a clinical trial to help advance new drugs so we can bring new therapies forward that may be better than what we currently have.
Thank you, sir. Next question for Dr. Pandit, for our medical oncologist. And it's also a question that has a really long answer, but I think he can keep it short. What is genomics, and how will that change the way chemotherapy or treatment of cancer is done in the future?
Thank you, everybody, for coming. We all are unique. We all are special. And what makes us special is the genes or the chromosomes that we get from our parents. Similarly, all the cancer are unique. They are special. Some are more deadly, some are less deadly. We treat cancer in two ways. One is by using chemotherapy, which is like using a bulldozer to go through the other side of this room. Or another way is to use a key, a special key to unlock the door and go to the other side. For example, there was a deadly cancer called chronic myelogenous leukemia, or CML, and a couple of doctors in Philadelphia found a genetic abnormalities in that cancer. It is called Philadelphia chromosome positive. And now we have a special medicine or a special key to unlock that gene. And people with chronic myelogenous leukemia tend to live forever. So genomics in cancer is to identify the special gene that we can target with a special key so that our patients can live forever. Thank you.
Great analogy. Thanks, Dr. Pandit. Next question, I'm going to give this one to Dr. Leach, but she can share if she wants. But what are your suggestions for engaging family to help with taking cancer patients for walks, talks, with their diet, and also funds for travel? It is really expensive and tiring, so a little bit of help would be great.
I will say I can't underscore the importance of a support system enough when it comes to exercise anyway. A lot of our studies now, we are engaging the caregivers as well. Kind of the next area of research that I think will be coming out will be something called dyad research, where we're looking at the patient and the caregiver together and how those relationships affect their behaviors and how we can change the behaviors of both the caregiver and the patient together. So yes, very important.
I think the other thing, just in regards to diet and travels and incorporating family, is really just to find a common purpose. So if you're wanting to make changes in your lifestyle for yourself, then really ask your family, okay, what kinds of things do you want to do? What kinds of things are important to you, so that you can find something that you all can work on together? And then really the planning ahead. just kind of if you're traveling, if you're planning meals, if you're doing something, just talk about it and have a strategy. When you have a strategy moving forward, it makes it a lot easier to implement changes and to kind of check off your list some of those healthier changes that you want to make.
And Sherry, there were quite a few questions for you after your talk this morning. There's a couple where the audience would like to know kind of the pros and cons of two different things or different things. One of those is fake sugar. What are the pros and cons? Also, what are the benefits of vitamin D versus vitamin D3? And the third one of those is, what's the difference between farm-raised fish or fish that are caught in the wild?
Wow. Okay. So we'll start with the last one and move back. So farm-raised fish and fish caught in the wild. There's a couple differences between those. A lot of it has to do with food supply and their environment. And so when you think about farm-raised, they can be more controlled. They're fed certain foods or a certain food supply. They don't have as much of the activity or natural flow of things, no pun intended, for their water source. But I think that there's still some risks with both of them. I know that with salmon, farm-raised salmon can tend to have some higher toxicities than wild salmon, but wild salmon also still has mercury that you have to be careful of if you're taking in large amounts of salmon. So the important thing is to get a variety. Remember I talked about this morning, choose multiple sources of fish. Don't just go all with tuna, all with salmon. Just make sure that you're getting a variety. And really do your research. Look for the Monterey Bay Aquarium Seafood Watch. Look for your low mercury sources, your low toxic sources, whether they're farmer raised, and choose, or farmer natural, and then choose those that are best for you there. As far as the vitamin D, I'm assuming that's vitamin D2 versus vitamin D3. There's two different forms available in our supplements. The vitamin D3 is the form that is best absorbed into the body. It's actually the form that you would find, in a lot of your more potent supplements. A lot of the supplements that are used to bring you up to a non-deficient level. So if you get diagnosed with a deficiency, the physician would recommend like a 10,000 IUs of vitamin D for typically 6 to 8 weeks to bring you up to that, bring you out of the deficiency. Occasionally that is a vitamin D2, but it will still bring you up to that level that you need to be at. But should really look for supplements of D3 if you're going to be buying a supplement yourself. And then the first one was the sugars. So there's a lot of different sugars. You have the saccharin, you have the NutraSweet, you have the Splenda. You have a lot of different artificial sweeteners. There's not a lot of evidence other than for the saccharin, which that has really decreased a lot in the market. But with some of these other sugars, you want to be really careful just with those foods. Still can have calories if they are like a carbohydrate or, just another form of food source. If you're looking at a calorie-free beverage, you still want to be careful with that because it's still a sweet taste, and it kind of can mimic some of that trigger in your brain for you to actually eat more. And so you just really want to be careful with your use of those artificial sweeteners. I tend to err on the side of, really just going with more natural foods, trying to avoid any of the artificial, try to avoid any of the excess sugars as well, but really finding that balance so that you're not getting all those other extra things we really don't know a lot about yet. I'm probably thinking that that's clear as mud, but hopefully that helps answer your question.
Thank you very much. The three-parters are always tough ones. Back to Dr. Davidson. A very easy question, hard answer. is there a doctor shortage in Grand Junction, especially primary care?
That's not an easy question. No, I'm kidding. There are really two answers to that, and we could talk a long time about that. But the answer is yes and maybe. On the yes side, if you are a patient who is covered by Medicaid or Medicare, it is difficult to find a primary care doctor. So on that front, I would say yes. It is. We do have specifically a primary care physician shortage and a number of specialty shortages. When I say that the answer is maybe, one of the things that's going on in the medical community all throughout the United States is looking at the proper scope of practice for everybody who is a provider in healthcare: physicians, advanced practice providers, case managers, care coordinators, all of those individuals who comprise the team that takes care of an individual when they're really sick, specifically, or as an example with cancer. That's a relative shortage of physicians. It is difficult to create more and more and more physicians. It's at least a 7 to 10 year process, depending on whether or not you count college or not. And what I think as a healthcare industry we need to look at is who along the pathway can we teach to do things so that we can have our physicians operating at the absolute top of their license, and then to relieve them of some of the things that they're doing now that so many other well-trained and good people in healthcare can do. So that's my long answer to a short and easy question.
Thank you. Very much appreciated. Dr. Rock, back to you. Kind of a two-part question. So the first part is radiation therapy safe? And the second part is, how does the doctor know which area to treat with radiation, and how are the internal organs protected from that radiation?
So yes, radiation is safe. There are risks associated with any kind of treatment that you get, and the name of the game in radiation is to deliver the radiation where you want it to go and not deliver it where you don't want it to go. So you don't want it to go to normal structures, and you do want it to go where the cancer is. So there are multiple ways of maximizing the dose to the cancer and minimizing the dose to the normal structures. So the process, the first part of the process is to do planning for the radiation, and we do a CT scan to do that in every patient. And then we take that information, we outline the normal structures that we want to decrease the dose to, and then we outline the tumor that we want to treat. And then there are different ways of delivering the radiation. It's really cool technology. I mean, the best part about being a radiation oncologist are the patients you work with, but another cool part is the technology. So there's something called intensity modulated radiotherapy, which just really enables us to conform the radiation dose to the area at risk and really decrease the dose to the normal structures. There are, well, I think Dr. Carlson, and I don't know if we have a question on this or not, but I noticed in my bio it talked about heart sparing, and that's another thing that we do when we're treating left-sided breast cancers, for instance. We want to minimize the dose to the heart. So we have an optical sensing system in the room that senses where the chest is when the patient breathes, and only allows the treatment to go forward when the patient is in deep inspiration, and that moves the chest wall away from the heart and minimizes the dose to the heart, which is really great technology, which we've had just in the past few years. So what was the other part of that question? Is that about it? Okay.
Perfect. You even covered your next question. So, Dr. Trowbridge, this is kind of a tough one, but pick out your favorite. But what are some of the latest techniques in cancer surgery? Do you have your favorite?
Yeah, and in head and neck cancer, the trick has always been to really optimize function for people after cancer surgery. And so, you think about all the things that we do as people with speaking and swallowing and breathing. All of those play a huge role in our decisions about what to do in terms of treating cancer of the head and neck. One of the huge advances really in the last 10 to 20 years has been probably the decreasing use of surgery in advanced cancers. And so people that would need very, very large operations that would be very debilitating now can often be treated with combinations of chemotherapy or radiation treatment. And so we're really able to optimize people's function after their treatment. The other is that just our techniques for removing cancer and reconstructing things that we might need to remove, portions of the tongue, portions of the throat, portions of the voice box, have become progressively better in terms of our ability to do those for people. So I think we're constantly in this balance between wanting to get rid of the cancer, but at the same time leaving people, as functional as possible. And the huge gains have really been in not doing surgery in people who have really big tumors, and in having much better reconstructive options in people that have smaller cancers to remove.
Thank you very much. Another question for research. Where do hospitals get their clinical trials from? So where do these studies come from? Marty?
So there are several sources for clinical trials, and if you think about clinical trials, a lot of the things that Dr. Trowbridge and Dr. Rock just said, their advances are all come through clinical trials. So if it's a surgical procedure that might be something that at a major academic institution, a group of surgeons might get together and say, we want to try this technique, see if it works better than existing therapies. So that's one way things happen. Now, that would be in a large academic institute. In a community hospital like St. Mary's, we get clinical trials from directly from pharmaceutical companies that are interested in testing their drugs or their procedures or their devices. And so they come and talk to us directly, and we set up a trial that way. Another way is we might have what is called a clinical trial network. And so the network might consist of a hub area, and that could be either a university like University of Colorado, or whom we participate in clinical trials with at St. Mary's, or it could be the other group that we participate in with, which is UCLA. And so they talk with the pharmaceutical companies or the device company and set up a trial that they then distribute throughout their network. So it would be a number of hospitals around the country, for example. And then the third method is the National Cancer Institute, for example, and NIH have opportunities to set up and run clinical trials that they sponsor and they run. And so we can participate directly with them. And so, again, at St. Mary's, we participate as an aligned affiliate of the University of Colorado to get these National Cancer Institute and National Institutes of Health clinical trials. Those are the main ones. The final one is investigator-initiated studies, and those can be Dr. Rock, for example, or Dr. Trowbridge or Dr. Pandit could say, I want to try something new, and set up a trial and run it either at their hospitals or get a bunch of other hospitals together and other practices to participate in that study. So that's pretty much the main mechanisms where trials come from.
Thank you, Dr. Jacobson. Back to Dr. Pandit. I need to read it first, sorry. Are oral chemotherapy drugs better than IV drugs, or what exactly is the difference?
All the medicine, any medicine that we consume or we take that goes to blood, and with blood it goes to every part of the body and kills the cancer cells. The chemotherapy that we give by IV, intravenous, goes into the blood immediately and kills the cancer cells immediately. But that requires going to the doctor's office or infusion center, having a port, and also if the chemotherapy has lots of side effects, then the side effect would be immediate, sometimes even life-threatening. Many times we cannot eat the chemotherapy drugs because our tummy has acid, and that kind of destroys the chemotherapy. And sometimes we can come up with some technique to prevent the destruction. And those chemotherapy drugs, when we take, it goes to our body, it gets then metabolized or changed into an active drug by the liver, and then works. At times, it's kind of difficult to control how much drug is going to be absorbed and then converted. So there are some benefit of IV drugs, and there are some advantage of pure drugs. But depending upon the types of chemical, it's hard to tell. But both can have serious side effects, and both may have benefits. Satisfied, or?
A lot of these are very involved answers, as you can tell, which may not be able, you can't always give it justice in 2 minutes, but thanks, Dr. Pandit. Here's another question regarding mental health. What are the mental health effects on cancer patients and their families throughout the stages of being diagnosed, treatment, and the aftermath? I'm going to see if Dr. Leach would try to give this a shot, and if she needs to pass it along, she can do that.
I don't know if that's my area, but I did just return from a conference in psychosocial oncology. So I did learn a lot about the importance of psychosocial resources for both the patient and the caregivers. You know, it starts from the time of diagnosis through survivorship, and I think knowing that these resources are available is kind of step one. So I think maybe I'll pass to some of the St. Mary's folks if they want to talk about some of the resources available.
I think the best expert probably isn't up here, but since Mike stuck his hand out, I'll gladly give it to him.
Yeah, I would just comment on the question about mental health during cancer treatment. There's a number of studies looking at the stages of cancer treatment and how people do mentally with it, mostly looking for depression. And there's a number of depression scales that can be used that, basically ask people how they're feeling, how they're sleeping, what their thoughts are about life, the kind of support that they're getting. And those scales are used for people who don't have cancer as well to diagnose depression. And I think it's thought that, at least in head and neck cancer, somewhere between probably 20 to 40% of people from treatment or from diagnosis through treatment suffer with depressive symptoms. I think that's only natural, and a lot of it is, I guess, what we would call reactive depression. I mean, they're worried, they're scared, they're undergoing hard treatments that make them feel badly. I think there's also studies that show that number may be about the same in the early survivorship periods, and I think I've always thought one of the biggest risk areas for cancer patients is when they finish treatment. Because while you're going through treatment, you've got lots of people swirling around you and taking care of you, and lots of stuff to do and appointments to make, and then sometimes the treatments abruptly come to an end, and people are then left sort of wondering what's next in life. And I know there's been a number of efforts in survivorship, looking at depression, but maybe somewhere between 20 to 30% of people can benefit by medication treatment of depression or psychiatric treatment of depression during their cancer treatment.
I think this is a great question. I think sometimes we as physicians struggle with looking at other aspects of patients. We get so zeroed in on their cancer and trying to take care of that. It's like we have a prostate sitting in front of us instead of a patient. So you know, they're really good about training us and giving us opportunities to be trained on the whole aspect of the patient and their mental health and their sexual health and their social health. So they're trying to help us out so that we're a little bit better than that. And then we have ancillary people who are wonderful, our nursing staff and our social workers and our survivorship people that can come in and you know, help fill in where we clearly have some deficits as physicians. So we're trying to be better at looking at the whole patient in all aspects of their health and not just looking at them as a, you know, a cancer case.
I have a question that's you know, more of a personal one, but it covers some good territory also, and it's for Sherry. But here's the question. I had bariatric surgery and colon cancer with bowel resection. Vitamins and mineral supplements differ, as do food requirements. So protein's the focus for bariatric, fruits and vegetables for cancer. Is there a balance?
Of course, there's a balance, and that is a very difficult case for who posed that question, because between the bariatric surgery and the colon resection, there is a lot of interference with normal GI function and absorbability of the food that's consumed. I think that, you know, anytime you can meet with a dietitian, nutritionist to be able to sort through, you know, how much GI tract do you have, what is your capabilities as far as volume tolerance, and then really look at you know, what you can do for protein in form of protein powders or other types of sources of protein that is easily absorbable, and also looking at you know, options as far as fruits and vegetables, as like juicing, smoothies, those kinds of things where it is broken down more. There's a lot of great products that are out on the market that can really help with that. Even the little, you know, you see the kids with them with the little pureed fruits and vegetables, you know, something like that would be really a good way to get some of those nutrients without having the volume that would really preclude you from being able to eat the 7 to 9 servings of whole fruits and vegetables a day. So there is a lot that can be done. Even supplements have come a long way as far as absorbability. There's you get fat-soluble vitamins that are easily absorbable in a water-absorbable form. You can, I mean, there's a lot of different options. So really, that is an individual question, but seek out a nutritionist who, especially if you can find a nutritionist who's certified in oncology nutrition, to be able to really sift through what you're doing to make sure that you have your plan and how you to meet your needs.
And most big hospitals do have a nutritionist, and actually several on site. So that's a good recommendation to track them down. The next question is, I'd like to know what's going on with my body and try to read the pathology reports. This is more common now that we have my chart and other ways to look at results. But where can I go or look to you, or what can I use as a resource to decipher all this stuff? I'm going to give this to Marty.
Yeah, this is clearly a research question. You're trying to research what it means. I would say, and in this case, I would answer it as a patient would look at it. I would say I would go to my physician and talk to them and ask them what all of this means. So for the pathology report, clearly you're not going to get to the pathologist, but you can go talk to your primary care or your specialist to find out what what does this mean and how does it impact your future care? Doug, you want to take, or Mike, you want to take it?
Yeah, now that we have all these electronic medical records, one of the things we battled with is how quickly the information is available to patients, because sometimes we would like to see the patient and talk to the patient about what the report means, because when they read it first without any interpretation, it can be, damaging and uncomfortable most of the time. So I want to say on some things now, they're in the hospital at least, there is a little bit of a block so that people can't get their pathology reports the minute that they're out, to allow the physician to kind of discuss it with the patient. But yeah, I think that the right answer to that question is to talk to your doctor about it. The doctor that did the biopsy or sent the specimen is the one that can best interpret that information for you.
Thanks, Marty. That was off the cuff, kind of a question, but we do have a roving microphone. If there's any other questions out there, just raise your hand, and then Jim will find you. One in the back. So while he's doing that, we have another question. What type of a checkup should I expect from my doctor to make sure I stay cancer-free or catch a recurrence early? Should they be testing for tumor markers? And I look at this as a survivor going back to primary care. Should that doctor be still checking tumor markers? Dr. Pandit?
Prediction. It's very difficult to predict future. And we all of us want answer about future. That's why we go to the doctor, get checked, and none of us want cancer, right? None of us want. But we just cannot predict things in life, and that's why there is this whole kind of industry or healthcare industry that is trying to find a way to predict something for us for future. And as we all know over here, that if we can catch cancer early, we can potentially cure the cancer. But that's not always the truth. And for that reason, but either way. So because we want to catch cancer early, that's why we undergo checkup, and then there are some tumor markers that we try to use to see whether we can detect the cancer early enough to check it. And as of now, there are not any tumor markers that can actually predict that how long we are going to live. There is a big back and forth between the PSA for prostate cancer, and right now we don't use it to predict or diagnose cancer. We use that tumor marker just to monitor it. So it is kind of very tough things to predict. Did I answer it or no?
I think the more, where'd that voice come from? I just want to add a little follow-up to this one, and then we can go out there to Jim. I think the main question is, if someone's had cancer, now they're cancer-free, and while they were with their medical oncologist, they were getting a tumor marker check maybe monthly, and now that they're away from their oncologist, would that same tumor marker be useful, say, 3 years out?
It depends. For example, if a person is diagnosed with colon cancer and his tumor marker is high to begin with, and after surgery, if the tumor markers goes down, then we can continue to follow that patient with that tumor marker, and then when that tumor marker starts to go up, then we can do further tests such as CT, CAT scans, or even x-rays, or even physical examination to try to diagnose the cancer early enough so that we can do the surgery again and cure it. Yes, there is some role of tumor marker once it is diagnosed, but there isn't any role of tumor markers before the diagnosis is made.
Okay. Thank you very much. Okay, Jim?
I was wondering if there's any way or resource that we can look into to push for a younger age of checking on colon cancer. Right now, the insurance companies and the average age is 50. I know lots of people under the age of 50, I'm under 50, who have been diagnosed with colon cancer, and it was, in some cases, misdiagnosed or hard to push. Is there any way, like they did with breast cancer, to be able to push for a younger age of screening for colon cancer?
I know for a fact about 15% of all colon cancers are under the age of 50, so that's an excellent question. Anybody want to tackle that one?
That's a very good question. Now there is a lot of data supporting that many younger patients are diagnosed with colon cancer. Younger meaning less than age 50. And there is a huge push by Medical Oncology Society for screening colon cancer early. And also, people with a history or family history, if a mother or father or uncle or aunt or cousin are diagnosed with any types of cancer, then it is a very good idea to talk with the physician that I have a family history of cancer, do I need to be checked? And many times, the cancer family history are linked to many different types of cancer. For example, pancreatic cancer can be related to a breast cancer. A gastric cancer can be related to ovarian cancer. Yes, any cancer, if it is diagnosed in the family, it is always a good idea to talk with the family physician and ask for some kind of screening test.
And I know the American Cancer Society is pushing for the ability to do the colonoscopies before the age 50 a little bit easier than what it is now. I know it's more challenging. Great question.
I was just curious about the clinical trials that you do. Does the patient pay for those, or does a hospital cover that, or who?
Turn this back to Marty.
The answer to that is yes and no. So clinical trials in the very early days, the sponsor of the clinical trials often paid for the whole thing. And so that kind of became an expectation, but they also realized over the years that they couldn't afford to do that because that raises the cost of bringing a new drug to market and therefore the cost of the drug. So what's happened in more recent years is the sponsor will pay for those parts, those activities and drug that are strictly associated with the trial. But remember, I said that a clinical trial, you get a drug, but you also get standard care. You have to get standard care. We can't give you anything less than that. The standard of care part of a trial is usually paid for by the patient or the patient's insurance. So you might, for example, get a chemotherapy plus a novel drug as part of the trial. The chemotherapy, which is standard of care, would then be paid for by insurance. The novel drug would be paid for by the study. And then any tests that are required specifically by the trial but would not be standard of care, the study would pay for.
Did that help? Good.
Other questions?
I'm just curious if some of the targeted genetic therapies that we've heard about for some cancers that have been so successful, are those likely to be useful in all kinds of cancers in the future? And is that something we should be expecting to see anytime soon?
Dr. Pandit, back to you.
In year 2001, Time magazine published a cover photo saying that we have a magic bullet about the Gleevec or imatinib for CML. That was the targeted, one of the first targeted therapy for cancer based on the genetic mutation that they were able to unlock. And we felt that there is going to be a big rush, or there will be so many other genetic targeted medicines. And they are popping up slowly. In fact, we have more than hundreds targeted therapy currently available for various types of cancer. For example, for lung cancer, there is a special gene mutation called EGFR, and we have a special medicine, Tarceva. Similarly, we have something for kidney cancer. Even for, there used to be a cancer called GIST. Now we can use simple oral pills to treat that patient. Yes, there are drugs coming, but they are coming slowly. And it takes about 15 to 20 years from the identification of genetic abnormality, finding a compound or a chemical that unlocks it. Then they have to put that compound or the chemical in pre-clinical trial, which include testing in the mouse and a dog or a monkey. Now we have to test that in the 2 different kinds of animals. Then we test that in the healthy volunteers to find out the toxicity. Then after that, once we find out the dose, then we test actually in a normal or the cancer patients. And it just takes time to develop a drug. So yes, in future, if we all live long enough, I think cancer will be cured.
So there are a number of drugs that have come out on the market recently, some of the immunotherapies, that show great promise in certain types of cancer. And the hope is that they could be used in maybe all types of cancers. In some cases, that's true. Clinical trials are currently in process with drugs like Opdivo and Keytruda to see if they'll work in other disease states other than what the FDA has already approved them for. Sometimes that's not going to work because cancer is not one beast. It's about 200 different diseases. And even within the different 200 diseases, there's different types. So the same drug, even though it has great promise in 1 or 2 disease states, may or may not have efficacy across the board for cancer. So there's never going to be really one magic pill that will take care of everything, except for maybe the healing waves of Dr. Rock.
Question over here, Dean.
I can't find you. Oh.
Hi, I'm Joanna Feather, and I would really like to thank you all for being here. I had a son that had been diagnosed at one time with a brain tumor, was fortunate enough to have Dr. Rock. We used a lot of other resources, and that's my question to you. When do you call upon another resource, such as the University of Colorado or MD Anderson, and how does that work?
So there are some times when there are very unusual cases that are not common, that will send the patient to a larger institution that sees a lot of those cases. So that's one instance in unusual cases. And I have no problem in just, kind of run-of-the-mill cases. If a patient wants to go seek a second opinion elsewhere, I think that's great. So we'll help facilitate that as well. I think, sometimes for a patient's peace of mind, they just want to have a second opinion on it. And that's, even though it's a very common cancer, and we all us radiation oncologists go to the same meetings, we have access to the same information. St. Mary's has the most up-to-date equipment that is available, but sometimes patients still want to go to another institution just to get a second opinion and for their own peace of mind, and that's great.
Dean, kind of a follow-up to that question, if I may.
Yeah.
Question for Dr. Davidson. St. Mary's has some long-standing collaborative working relationships within the Sisters of Charity system with their other facilities in the Denver area, as well as CU, and as Marty mentioned, UCLA. Can you comment on the benefits to cancer patients in our service area over here that they have as a result of those relationships?
Sure, that's a great question. I think being a physician myself, one of the things that is part of the physician world is that there's a lot of work to be done. There are a lot of patients who want and need you, and information is moving so quickly about what you should be doing for patients. The standards of care are moving, protocols, clinical pathways are moving, and I think this is where, as Dr. Rock was talking about, we all have a network of individuals that we can call that have special interests in different areas that may be able to advise any one of us on any topic. I'm an anesthesiologist, so I'm other than keeping people still and quiet and pain-free, so that the oncologic surgeons can work their magic. But we all have those networks, and when an organization like St. Mary's has a relationship with a world-renowned cancer center or a network even just on the Front Range as far as SEL Health, these are individuals that you can pick up the phone and run a case by them. And that's not a situation where the person on the other end of the phone is necessarily any better or any smarter or any of that. There's too much going on in healthcare, and there are too many details for every single individual physician to keep up with everything. And the good physicians know that. And the ones that sometimes want to send someone for a second opinion or just say, hey, you know what, this is a little bit different than what I've seen before. I'm going to call my colleague in Denver or at University of Colorado or at MD Anderson or wherever they may have a network and just run your case by them. Is that okay with you? Say yes. That's a good thing because that's a good doctor using that network. So I would say our partnership with so many organizations allows for that consultative piece, and it also allows us to keep up with all of those protocols and clinical care pathways and those standards of care that change constantly. Fortunately, in anesthesia, stuff doesn't change that often, so it's a big deal when something changes. But in oncology and some of the other specialties, they're changing monthly. You get a new journal, a new study, a new meta-analysis comes out, something's changed, and it's difficult for even the best of physicians to be taking care of sometimes hundreds or thousands of patients and read every single line of their journal and every website and keep up with that. So the good ones have a network, as all of these individuals do, and they use it.
Dean, we have one more question over here, if that's okay.
One more, and that's our last question.
Well, then the microphone's going out the door. So.
Excellent. Okay, please.
In regards to the body scans, which seem to be the latest rage now, can you take that as face value that you're cancer-free if they show that there's no signs on the body scans, no tumors, no lesions, no anything like that, or no?
Dr. Rock?
I think there are as far as screening goes, there are specific recommendations for screening for certain cancers, and I think I would follow those. You can find those on the American Cancer Society website. As far as, when I see a patient in follow-up and we do a CT scan to see if we see any evidence of cancer or do blood work, it's not a guarantee, unfortunately. So when I tell a patient that I don't see anything on their CAT scan, that's what I tell them. There's no evidence of cancer now. There's probably no exceptions. I don't know that I can ever tell a patient, I know 100% you're cured, because cancers can still come back. So I always tell patients, I don't see any evidence of cancer right now, but we need to keep close watch on it. So, what's that? Oh, like imaging studies? There'd be a different test for the most part, so, yeah.
I think there's three ways that doctors really look to see whether people's cancers have come back. One is doing a good physical exam and asking questions about people's symptoms. And for us in head and neck surgery, that's probably the very best. I mean, better than x-rays, better than blood tests, better than anything else. So oftentimes we ask people to come back every month for a couple of years to be examined. You know, a second one is to do x-ray tests, and there's a whole variety of different x-ray tests that are all kind of indicated for different types of cancers, from CAT scans to MRIs to ultrasounds or other things. And then the final one are these blood markers, and there are specific cancers for which blood markers are very accurate and helpful. There's a lot of other cancers for which blood markers there are none. And so blood tests are not useful in certain cancers. You know, we usually take the approach that curing a person's cancer it basically has to do with time. And we know statistically, if you treat somebody for cancer and their cancer goes away, you know if that holds for a certain period of time, that you have a very good chance that it's gone. And during that time, just statistically, we follow people very closely to look for any of those indicators of early recurrence. It's tough on patients sometimes because every time they come to the office, they want the reassurance that their cancer is gone. And sometimes what you have to say is, well, the studies say that if you go 2 years and you have no recurrence of cancer, then you have a 98% chance of being cured. So we're going to watch you really closely for 2 years, and then we'll have a party at the end of 2 years. But it's difficult on patients in between times because they want the answer that it's gone and it's never going to come back.
Thanks to everyone on the panel. I think you all did a great job. This is a hard role to fill on the spot, getting questions. So let's give a hand for the panel.